I'm going to start now. More people I know will be coming in. This is a very important topic. I'd like to thank Veradigm. And Brian Hall is here from Veradigm, a leader in revenue cycle management, as well as this topic, as well as sponsoring this session that makes it all available for everybody. Our goal is that we solve this problem once and for all tonight, which is exactly, of course, what we're going to do. This is the current state of pre-authorization, I think. At least in my office, this is what we do. We use the weed whacker for peer-to-peer reviews. The rest we'll have to see. So I'm going to start off with asking the key question, first of our panelists, and then anyone who wants to ask. What is the nature of this problem? I mean, what is, in your opinion, where has it gone south from maybe 20 years ago, 30 years ago, when you saw somebody, you said you needed a knee replacement, they needed a shoulder arthroscopy, and it just got done? Maybe Scott, you want to start us off, the one real fro? What
Yeah,
what's going on now?
yeah, I think that the commercial payers have taken over, and in their responsibilities, they are trying to earn money for their shareholders. And at the end of the day, that means by not providing care. So the least amount of care that they provides more revenue for their shareholders, and that's at the expense of the employers and the employees that are now responsible for paying for their insurance policies.
Right. And I agree with that. I mean, there's no question that is the big picture from 30,000 feet. We see on LinkedIn a lot of posts. I know David Crawford's here tonight he had a very popular pre-authorization post. But like Moby, what is your experience lately? Let's say the last 6 months with the pre-authorization process.
I mean, I tend to feel it worst in the first quarter of every year. And I think that's, partly an issue like Scott mentioned, because most of these are publicly traded large health insurance companies that are, beholden to their shareholders. It is a bit more complicated than that, though. And I think at the outset, the concept of prior authorization was not such a bad thing, right? It was somewhat designed to limit unnecessary care and overutilization. And as much as we all like to think that we're all great physicians, it is a problem out there. There are bad players in the market. And now that the market is going towards more self-funded employers that are using the insurance companies as a third-party administrator, part of the problem is they're selling prior authorization as a cost containment strategy, which sounds very attractive to a self-funded employer. The problem is it's not really working in a cost containment fashion. Part of the problem is that MSK spend has become one of the number one spends for these big employers across the nation who are providing benefits to their employees. And so MSK spend is going up higher than cancer care, higher than cardiology, higher than imaging. And so they have to offset that somehow when they're acting, kind of as a fiduciary to their employees, and when the third party administrator is trying to figure out the actuarial data on
Yes.
how they can save money. So it's a math problem, and it's a byproduct of fee for service. And as the costs have risen, this is where we're at. It's
Brian?
very complicated.
Yeah, it's getting complicated as we speak. Brian, some comments?
Yeah,
Brian Hall, and then Brian Fuller. Yeah,
yeah, we got the two Bryans and the two Fros.
two friends.
Yeah, I would echo a little bit with Moby, right? I think it's become a very much a cost containment mechanism that had value early, and I think has consistently gotten out of hand. And I agree on the self-employer side too. We see it there where it becomes a mechanism for them to potentially control costs. And obviously, I think we're seeing more and more of it. But the level of complexity probably in the last decade, maybe in the last 5 years on prior auth is layer after layer, and it is becoming, as we know, a continual problem. And I think where it was meant to do good is if essentially turned into creating just an epidemic that's driving up costs, not driving down costs.
Brian Fuller, any comments?
Well, I'm the youngest guy on here, so I don't know what it was like 20 years ago to say I wanted to do surgery and get it done. That world has never existed for me. But I will say I do think it's worse since January. So what Moby said about Q1, I think that's absolutely true. My office just hired a second person whose only job is to deal with prior authorization. And I had 15 cases canceled or rescheduled in January alone due to insurance, whatever. And so it's a problem. That's what I know.
So I want to show it. I want to first of all show an image. If someone would like to speak, please put a question in the chat room. Would be nice if you want to put a question in the chat room for everybody, and then I'll call on you. I'm going to show this image. This was a part of a program. Just sort of a thing I'll talk about later called the National Authorization Project, where people are sending in horror stories. This is a company, Turning Point, which many people may or may not know, for a knee replacement, 27447. They wanted an MRI with descriptive criteria. Okay. All right. Do we have anybody who supports what Turning Point wants here? So this just gives you an idea of like you almost don't even know what to say, and things of that nature and stuff. Greg, you had a question? Greg Brown?
Unmute there.
Okay, sorry.
No, actually, when I was back in Minnesota, we had something similar where actually I think it was Blue Cross Blue Shield said they wanted outer bridge grade 4 arthritis documented. I pointed out to them that meant we were going to do a diagnostic arthroscopy on every one of our arthritis patients, and then they finally realized their mistake. But clearly you don't have any clinicians involved in these things. I was just going to say, I don't know about the good old days, but it used to be Medicare was the best because you never had to get pre-authorization. And now with Medicare Advantage, that's all down the tubes. And so I think that's another big impact for a lot of arthroplasty patients.
Yeah. I'd like to ask a question of anyone who would like to sort of raise their hand and answer this. Is this problem to some extent a byproduct that, as when Moby said, there's some bad players out there? Did we not police ourselves? I don't want to say police ourselves, bad word. Did we not do enough quality control in our hospitals and our communities or as medical societies? Is that a realistic thing to do? That has been brought up. Okay. We have Moby. You want to say something about that?
I think
your hand, you were holding the eclipse. I'm not sure.
Yeah. There might be some element of that. I think that there are some people that have gamed the system. There's people in my community that do this, that order an MRI on every hip that has bone-on-bone arthritis, sell that patient a brace, run them through their PT, and just basically submit claims to the insurance company and then eventually do surgery on it. But the other problem is the nature of the way that these health plans are constructed, right? So if you're Blue Cross Blue Shield, what you want to do is create a big network of providers, right? So you have a huge network of doctors. If you're Optum and you own 90,000 physicians, when you're acting as the administrator of a health plan for a large employer, say you're Marriott and you have 70,000 employees and you're self-insured. If you go to them and say, look, we have this gigantic network of physicians, so your patients can go see anybody they want, That sounds very attractive to the company. Now, the
Mhm.
problem is that network has high quality physicians and low quality physicians. And the insurance company does not steer those patients just to the high quality people. They're selling network access to the company, which theoretically sounds attractive, but the patients and the people consuming the healthcare have no really clear way to vet who's high quality and who's low quality. So the problem is at the end of the quarter, when the actuarial people are figuring out what their spend was, there's going to be lower quality physicians. They may not be bad apples who are gaming the system. They may just be people whose outcomes are not as good as other people. And they're going to cost more money at the end of the quarter. And the way that the insurance company then has to adjudicate that is by reducing reimbursements to physicians, right? And charging higher premiums to patients and employers. And that's how the game works.
David Crawford, you mentioned something in the chat. You want to give us some thoughts if you're available?
Sure, yep. I mean, one of the things with insurance companies is that they can't be 100% profitable or they can't qualify as an insurance company. And so if you look at it, and I think it put 75%, but I think with the medical insurance, they actually have to have 80% losses on the premiums coming through. So at the beginning of the year, they hold the money back, they take all the premiums, they invest that, they make their money on the investment of those premiums. And then toward the end of the year, if they're only at 60%, 70%, and they actually need to meet the requirement, I think that's why it becomes a little less stringent toward the end of the year as they need to pay out these losses to actually be able to maintain themselves as an insurance company based on the regulations.
So effectively, you're saying they're using denials as a tool or a weapon to get to a certain financial goal.
I think because I mean most premiums are paid up front, whether it's annually or whatnot, so they can hold your money and not pay out these claims for 6 months and make 8-10% investment on that money, and then they would say, "Oh gosh, we're only at 70% losses right now. Let's start paying out all these claims." Toward the end of the year, they still made money.
Right.
Because I mean, if you're a self-insured business, that's different. You don't have to have a loss ratio if you're self-insured, and that's a whole different conversation, which is brought up because those folks really want to save everything they can.
That's 2/3 of the market. The
Yep.
self-insured is now 2/3 of the market. Yeah, the medical stop
They're
loss
also managed
ratio
by
is such.
TPAs. I mean, so these third-party administrators are managing this, usually, unless you're, the direct employer, like a big company like that.
Yeah. Jonathan Levy, you had a very good comment here in that. Are you available to talk, Jonathan?
Can you hear me?
Yeah, very well.
Okay, that's great. I sort of lost my voice, but yeah, I mean, I think a lot of us are dealing with this and fighting the individual daily wars, but I don't think it gets anywhere. I mean, I had an example today. I was denied a shoulder replacement on a patient who had gone to therapy 3 different times, but because they didn't do it 3 consecutive months, it was denied. And they quote clinical practice guidelines that define the authorization limits. And to me, we'd have to fight it at that level because we're not going to win the war on an individual basis. We had a representative from Aetna that was at our innovations meeting in January, and they were open to the concept. Like, if you can show us the evidence, every year we review our clinical practice guidelines that we can make change. So to me, the best form of advocacy is getting to the root. And I think we can sit on LinkedIn and complain. We can tell our stories. They're individual stories and they're going to get us nowhere other than just therapy for talking. But if we want to make impact, then I think we have to kind of group together and let the thought leaders define what a clinical practice guideline really should be, not based on insurance companies reviewing, some random journals that they finally found the evidence that supports what they want. And, we do shoot ourselves in the foot in academics because we often publish things that don't have great data, but it gets used in the wrong way. And the studies can hurt us. But I think, as a group, in a group like this, if there can be a way to focus our energy on creating clinical practice guidelines, I think it might be more effective.
Well, it's hold on, I have to admit somebody. Hold on. The idea of clinical practice guidelines, you're almost saying, not like the AAOS produced clinical practice guidelines, right? You're referring to truly pre-authorization guidelines. Is that what I'm hearing, Jonathan?
Yeah, if you read the denial letters, each insurance company for each CPT code you're trying to justify has a criteria or authorizations or prerequisites, and every box gets checked. So then when you do an authorization review, if you miss the box because they didn't do therapy for X amount of time or whatever non-surgical treatment before, then you're going to get the denial no matter what you say on the phone, unless you can produce the evidence from a therapist or something like that
Right.
that can justify it. So, but those guidelines come from somewhere, and they reference them in their denial letters.
Right. I'd like to call on Nelson Case. Nelson, you had an important comment. Are you available to speak?
Sure. Good evening, everyone. Yeah. Hey, Dr. Sigman, the real throw. No, I was just mentioning, I mean, from the administration side, trying to manage this with our revenue cycle department, there's a never-ending changing set of contract limitations, network benefits, the language that has to be used. It's just literally there are 50 updates in our revenue cycle platform every day. Who can keep up with that? I mean, that's a hot topic. I mean, we do our best. Contracting tries to keep us informed. RevCycle tries to enforce it, and we try to help steer the physicians towards the right language. All of you folks, and we do our best. The other thing too is the pace at which we can obtain these things for our providers and our facilities. It's inexhaustibly challenging. Like there's no interoperability standard for health information systems and revenue cycle with the insurance companies that's effective at this time. They're moving towards it, and there is a standard for it, but that alone slows things down. You don't even know until the last minute sometimes whether a case is going to be performed or not, or if one of the codes isn't going to make the cut, or if it's all going to be bundled and be considered diagnostic. I mean, the list goes on and on. And coming from the perspective of an ASC where we're fine tooth combing everything and trying to make ends meet, that's a real issue. It's a very serious issue.
Dr. Plancher.
Good
Kevin.
evening. I'd love to hear. I'm very excited that Veradigm's on the phone. They're renaming, and I thought maybe Brian could speak to some of his thoughts, innovation or ways or creative ways, because we have him here. I so agree with all my peers and whatnot, but I thought it might be a great opportunity, having heard some of it, so we're not so despondent, because I'm very excited that he is on the line, because I'm ready to listen, and maybe we have something, and that's what he does for a living as opposed to me operating, if that was okay, Ira.
Oh, no, absolutely, because the next slide is this
Yep.
one.
Okay, well, there you go. I am Ed McMahon.
Yeah, what is the strategy?
Okay, Johnny.
What are some of the strategies we're using now? Like I like to say, Brian Hall, best practices that we could look to now, because one of the first steps is we've defined the problem. We all agree we're all clinically depressed about it. We got that.
Yeah.
Okay. We could take one big Prozac and we're all done. But the reality is there are best practices out there. And I think Veradigm is a leader in this kind of stuff. So what do you think? A little pressure on that.
Yeah, no, I couldn't set up any better than Dr. Plancher did, so I appreciate it. Yeah, and I think just real quick, just to I think echo a couple of things before. We see the same trends on the rev cycle, right? End of year revenue comes through, and all of a sudden everybody starts holding claims in January and February, and we see the same thing at the end of every quarter, pretty much until the end of the year. So the trends tie all the way through, and it is no different than the self-insured groups as it is for the regular commercial payers. They're all using the same third parties and kind of ending up in the same results. So it is a consistent trend there. So I think there's a lot of, there's no silver bullet. I wish there was. It would make things a lot easier. I do agree with the idea that, I think Jonathan said we've got to essentially at some point come up with a standardization that everybody follows. Because I know looking at it with the outside, with the rev cycle lens, for total hips, total knees, shoulders, there are different requirements for every payer, for every piece of this. And not only for the actual prior auth, but through the appeals process and the processing side of it. If there is a denial on the prior auth, as a lot of them have different requirements there too, before you even get to peer-to-peer. So it is a dilemma. So there's a few things that, we see clients doing, there's a lot of different things, right? And I think there's the front end piece, and none of this is going to get solved by throwing more people at it. That's not the solution. I think we all realize that. I don't know, everybody on this call has probably got staff dedicated to prior auth, and if they don't, they probably need staff dedicated to prior auth. So there's technology is probably the way we look at it. And there's a few different things, right? There's the ability to automate pieces of this through either predictive scheduling and some of the automation rules-based tools on the front that we use at Veradigm. We've used it prior to my, when I was with Cohen, been in the MSK space for the last, almost 30 years. But the idea of looking at tech to solve some of this is going to be key. There's the ability, we're all familiar with RPA, robotic process. That solves a very small piece of this. Then you start to look at machine learning and AI that can actually submit the prior auths and actually go and dig out the data and really fill a lot of that gap for you. So there's the one solution, and the way to look at it now is solving the problem of dealing with the current situation. But at the same time, I think there's got to be the push to solve the other, obviously solve it and standardize it in a lot of ways. So I think there's the idea that you've got to make sure, one, everybody that needs a prior auth, which I think is probably happening, hopefully in all cases. Two is, and we run into this all the time. We were talking about, I think, war stories a little bit, Ira, where even on knee scopes where you go in and you do you think you're doing a lateral meniscectomy and it ends up you're doing a medial lateral and it's a completely different code, right? That's probably the most common, believe it or not, prior auth that we end up fighting for and appealing on our side, which seems pretty simple, right? Because the MRI may not have shown that it was medial lateral or whatever ended up happening in there. So there's a piece there, but it really comes down to two things. I would say one is identifying it with the tech, right? Is there a predictive scheduler? Is there a rules technology on the front end that's identifying all your patients and need auths? And then looking at tools that are out there. There's plenty of them. We've got them. Other people have them. I mean, they're there where you can leverage the automation piece and automatically submit the prior auths, attach the documentation. Obviously, there's still a human screening piece to this. And then two is the follow-up, right? It's great that we submit them. You've got to be able to automate that follow-up piece. And I think you can save, and we've seen this. I think the Baptist did it years ago in Boston, I think with one of the big groups that we work with, I think Brian McKeon's group potentially, but they worked on some AI stuff. They really helped their prior auth stuff there as well. So I think there's that piece of it and really leveraging that tech. And I think in the orthopedic world, sometimes we're all a little hesitant to invest, but you can offset that cost with labor savings pretty quick. I mean, we all know what an FTE costs today compared to what it did 5 years ago. So the technology, while it comes with an investment, you can offset that cost pretty quickly over the time. So I think that's a piece. I will say the other thing that to me, where we saw traction, we dealt with this, and Scott Sigman may remember this, but in mass, there was a couple of payers, Harvard and Tufts in particular, they were pushing additional prior auths on some imaging services, all the way down to, I think, knee X-rays at one point. And I do think there's a level of local advocacy that has to happen to drive this, right? We've worked with the Mass Orthopedic Society. I think obviously we all know that so this federal rule coming through on the gold card type scenario that I know now Mass and I think New York and a bunch of states are pushing through too. So I think there's a couple of different areas there, but I think we've got to figure out how to advocate, because a lot of it is local. It's not just federal, right? We know there's local payers. We all deal with it in our market as well as the national payers, and that's not going to go away. So I think it's a little bit of a two-pronged approach, but as far as best practices goes, it really comes down to the other piece I would say in there, and we see this a lot, is there's no perfect scenario where you're going to get every prior auth, every code correct, right? So you've got to be able to respond quickly to adjust that prior auth. And a lot of the payers, I think we now have 48 hours, 72 hours. Some go a little bit longer than that, but you've got to be able to identify pretty quick if you did something different than was on the prior auth, and whether or not that's through leveraging technology, whether or not it's speeding up how quickly the notes are getting dictated and back to your coders. But you really need to identify that in the first 24 hours. And we use some rules technology in the back end to help our clients do that, so we can at least get back to them or file the appeal to push it through. So there's no silver bullet, but I do think we've made investments in AI in several areas. And I think what you find is what's happened in the last 3 years with AI really allows it to improve the outcomes there. Combine that with machine learning and this whole RPA stuff, and the three together can really help solve the problem. But it takes an investment. It's not inconsequential, but it usually offsets the labor costs.
Very interesting. Any comments on that?
Hey, yeah, Ira,
Yeah, Scott.
I think we have to take some ownership as doctors here as well, right? Um, we don't do a great job in developing consensus. And, AI should not be the Cliff Notes version to figure out a way to be able to get a pre-authorization. AI is going to be a very powerful tool in how we treat our patients moving forwards. As a general rule, we get into an exam room, we have our opinions that have been developed from our mentors in the time in which we have become masters. We look at an x-ray, we examine a patient, we come up with a diagnosis, and then we develop a treatment plan. And it's a one-on-one environment with that single patient and a single doctor. And the question is, can we be doing a better job using artificial intelligence to be able to identify the risk factors that are associated with success or failure of a rotator cuff? Can we identify using artificial intelligence which MRI images are going to be the ones that create the potential for a successful outcome? And so I fully believe that artificial intelligence, once it moves in, is going to be a much greater tool than just a cheat sheet to allow us to be able to get prior authorization, but perhaps allow us as doctors, not just on research or individual studies, but to gather all of that information together to make us smarter and better so that we're doing the right thing for the patient, so that the insurance company has the data to say, yes, okay, we can see that these 50,000 patients that have been treated across these 30 doctors, this is the best possible outcome.
Does anyone else have some best practices that they use in their practices that kind of works better today than it did a couple of years ago? I know it's kind of an open question to a big group. Do we have any methods that people...
Just book more surgery than you plan on doing because several are going to cancel.
Yeah.
But Ira,
Yeah, that's
I
true.
don't know if it's sorry.
Go ahead.
I liked what Brian said, because you have to understand this is a game. And as we as doctors take it seriously, but this is just a game. So when the rules change, it's tough to play the game. But I will say for the group, I've always loved knowing this. They've tried 3 anti-inflammatories that had physical therapy for 8 weeks, and I'm very concerned. And through another doctor, they put the patient on the line when it comes and say, please hold on. I just want to put the patient on the line so they can listen to the conversation. I'm excited to talk to you. And suddenly, poof, it disappears. So I will say it's a game. So have a little fun with it.
Yeah.
Okay. Don't get upset. I understand it annoys us because we know the medicine of it. But if you understand that, it's not a bad way to go.
Alan Resnick, you have a comment? Alan.
Oh God, there's so much to talk about. Can you hear me?
Yeah, very well.
Yeah. Okay, great. So yeah, the gamification is a great concept because it really is. And I think the other thing that I found effective, which is just an aside because what you just said was so great, is that I just talked to the guy. So yeah, he says to me, your name's familiar. See, I wrote a few articles for AOS Now and a couple other things. I got a couple of publications, whatever. He goes, oh yeah, I think I read one. And we have a whole chat first before we even talk about the pre-auth. And before you know it, the guy's trying to help you fix it. So that I found very effective. Is like, you're orthopedic surgeon. Oh yeah, where are you? I'm so and so. What do you do? Okay, great. Well, I do that too. Boy, this is really tough out there. And these guys, they're kind of screwed. They have a rubric. They got to know what to do. If they kind of like you for 4 seconds, they'll tell you what you're supposed to do, even though they're not allowed to tell you, which really helps a lot. I don't like the idea of overbooking, but I understand that works for the airline. So that is an answer. I am concerned that the gamification is sort of like nuclear deterrence. They up the ante by getting AI programs to read our notes. And that's what's happening to me now is like, oh, you didn't say the phrase I was expecting you to say, like lateral release. You didn't say 20 degrees of tilt or more. If you don't say that phrase, even if it's 19 degrees and you really believe the patient has those symptoms, you don't say the right phrase, the AI kicks your note out. The other thing that's happened to me, which is problematic, and I find a new habit that helps that, is that person's seen 3 other doctors. I'm going to put that in the history. They've done everything already. My note details what my opinion is and what I think, but I've come to think that now I have a summary sentence at the end of every note for surgery. And the summary sentence goes like, so and so has been seen by 4 other doctors. They have done A, B, C, D, and E and F. I've evaluated the patient. I've found A, B, C, D, and F. The MRI shows A, B, D, C, and F. Had a minimum of 6 weeks of therapy. All the things I know right now work to get the thing done, but I find that I have to summarize it because lots of my reviews, I say, do you see the beginning paragraph? I said, do you see here that he saw 3 other doctors? Yeah. We don't have those notes. Okay. Well, okay, then whose fault is that? It's not my fault you're not pre-auth because you have notes. The patient's insured. You have all the notes. So I find that's helpful. So I really, it's the frustration thing to me is the game is we can up medical costs until the system bursts because we take 14% off the top. So if we figure out ways to make medicine really, really expensive, we don't care if it's drugs, the doctor, the hospital. We love squeezing the doctor. It's always their fault. But if we're now a $6 billion business and we could be a $7 billion business next year, we make another $140 million next year. And that's sort of the insidious underlying incentive. The insurance company's incentive is to make everything more expensive. But at the same time, they got to show the insurers they're doing the best they can to keep the doctors from running away with their money. And we'll never win in that scenario because we're just not in line with the incentives of the insurance companies at all. This is a losing game for us. I always call it the zero-sum game. They have an X number of dollars they're willing to give us. And every year we try to get a little more. And every year they try to give us just X. And as long as they can get to X, they're happy.
Interesting.
And so I said, yeah. So I just don't know how we win. And we can do all this stuff. We can do better results. We can prove we're good. We can get our robots to beat them if they're robots. They'll just change the robot next year to something else. Right. The last piece about AI, and I've written a lot about AI over the years, and the last thing about AI, and my concern, I've expressed this a number of times, is that AI is based on a set of data that already exists. The set of data, the assumption is the set of data you're working on represents the population you're evaluating now. And furthermore, the data itself and the AI action does not alter the population going forward. And the trap we have of all these systems using AI to get best practices is we then alter the population going forward forever. We have the best practice from 5 years ago. Going forward, everyone does that. No one ever finds out anything new. We keep reinforcing that that's the right thing to do, and we never get anywhere. And we get in this trap of circle that AI is predicting this is the right thing because it's the only thing we do, and therefore it has to be the right thing. And I think that underlying assumption in all learning, machine learning and LLMs particularly, is being missed by everyone, that old data gives you old answers and loses and increasingly squeezes out innovation. And we're seeing that now too.
Nelson Case, you commented a bit on an AI proving to be incredibly helpful in denial prevention.
Yeah.
Could you
Well,
comment on
so I do a lot of due diligence over the last 5 years with where I work and investigating any type of health information system, and some of we didn't pick all of them up, but I still follow them. Some of the best solutions and the best results I'm seeing in denial prevention were the bolt-on computer-assisted provider documentation solutions. Those have that AI. They look at the language that was needed, retrospectively, where the denials they still stick. Like you guys were saying, the specific wording of things, and whether you would not use the word open and having the fragment size, whatever it might be that has prevented a case from being paid correctly or timely following surgery, has built a really robust predictive computer-assisted provider documentation platform for a number. I'm not soliciting anything here, so I'm not going to name any vendors, but the literature that I've been following has been really compelling. It's something that I hope to see as a standard, as long as providers are open to, largely on the script here, if you're open to having that assisted documentation. That's all I was getting at.
Interesting. Brian Hall, any comments on that, Brian?
Yeah, thank you. Yeah, it's interesting. There's tools out there that, especially on the surgical side, that are essentially identifying the documentation deficiencies. And so not necessarily helping with the pre-auth, but definitely helping with the appeal process if you have to go through it on the surgical side. So we've used one for a couple of years now, a little bit longer, that essentially looks at all the documentation, the keywords needed on, for example, a total joint or a shoulder scope or whatever it might be needed to make sure that the documentation lives up to the requirements of the CPT codes and the ICD-10s that are necessary. I think that is again, to Scott Sigman's point, right? That it's solving the problem. It's not preventing the problem. I think eventually we want to prevent the problem, but ideally, I think that identifying documentation deficiencies, identifying the requirements in it, that technology is out there and it works. I mean, we've seen, in some of the cases where we've used it, 30 and 40%, of the cases we're catching and improving documentation. And these are third-party tools, not necessarily our tools, but it helps. Makes a big difference when you go through the appeal process to at least ensure you're getting paid, right? Doesn't necessarily solve the idea of having all the red tape on the front end, but.
Do those programs integrate into EHR so that when the physician, like we have all scripts in our hospital, okay? And maybe some people have Epic and some people have Cerner or some people have something else. Do they integrate real time in the sense that when my chief of joint replacement is on the call here, Ronald Wong, when he finishes his note, his final decision note, does it go through it and make some suggestions?
Yeah, it'll feed out. So it does integrate with various platforms, the Athenas, the Epics, all the big players out there. But essentially, it's taking it, reviewing it, looking at the exceptions, and then potentially having a higher level coder looking at it as necessary, then providing that feedback back to the provider. So it may not be instant, but it's in a relatively short period of time.
Yeah, it works hand in hand with coding AI as well, which is the inverse of this, and probably I'd say, equally as important. So coding AI not only is cost effective, but it seems to be the approaching the it's beyond the productivity curve. We're reaching a plateau, and we're going to see those players emerge and be standard and conventional in EHR integrations, I think, at some point.
Ryan Fuller, you got asked a question about maybe people on the call know the answer to that question about the CPTs for.
Yeah, I posted a picture. I don't know who posted on LinkedIn, but there allegedly is some codes potentially for reimbursement for the time spent on prior authorization. I don't know if anybody has any intel or is part of the advocacy or knows if that's a real thing or not, but.
Yeah, people can see that. I'll show it on the screen. You can see it now. So there's codes for prior authorization services. This means you getting paid a certain amount to spend time doing clinical, and it even says clinical staff. But this is proposed at this time, right?
That's my understanding. I did not post that. I saw it on LinkedIn, and
that's cool.
Yeah.
Like to see how the insurance companies put rates on that.
Yeah, right.
Well, they don't.
Well, at least
those are the same CPT codes we get for laser. They don't exist, but they're printed out, but nobody pays for them.
Yeah, they'll probably require a prior auth for the prior auth code. That's the
prior auth.
Oh, that's great.
Great move.
That's great.
That's great. So I'd like to kind of move a little bit. I don't know if he's still on. Is Doug Dew still on? Doug, I know you're kind of really quite an expert in this. Do you have any comments to share with us if you're still with us? So sorry to cold call.
I'm unmuted.
Oh, there you go, Doug. Yeah. So yes,
I don't want to do a commercial, but the problem was after COVID, let's say pre-COVID, you could have a knee scope and say they've got mechanical symptoms. You could say they've got a Baker's cyst. The MRI shows a tear. You could approve. Now, if you look at a knee scope, we actually mapped how many elements they have. Anthem has 270 elements. Cigna has 333. Blue Cross had 463. Humana had 49. United had 240. Olive had 17 and wasn't even following Blue's comments. And then Aetna and Medicare, have to get that approved. So what we've been doing is using the next generation machine learning to map all of the payer rules and turn it into a questionnaire to write a note. So I'm a little over 5 years with no prior auths turned down, no peer-to-peers, and also I know when not to ask Mother May I. So we've been doing a big project that we've done all pretty much all specialties from laboratory to all surgical specialties. We have about 500,000 files to keep track of all that information. And I can say with a straight face that I'm probably the only person on this call that's read every policy and every specialty of every payer. So it's there, but we've been very quiet on what we're doing.
Yeah, I knew you. I saw you working.
In fact, some of the payers are wanting to use that so they don't have to read the note because it's costing them just as much money. The other thing we found is the third parties, the Evercores, and those of the world in the Magellans, ones that are written by them have more elements to try to trip you up because in some cases they're getting a $500 peer-to-peer review fee, not for the doctor, but for them.
Right.
And so many of the Blue Crosses are starting to drop. So yes, I'm very involved in this. I wanted to hear what everybody had to say. In fact, I'm giving you a paper in a few weeks on all the different data elements of shoulders, knees, hips, the different major payers. It's real interesting.
Well, I have some reviewers online, so we'll make sure it gets reviewed in a timely manner. Yeah.
No, it's crazy out there. And it got worse after COVID.
Yeah. Interesting. Some comments about whether or not we can fight this with various rules and machine learning and putting it together. What do we think about that? Okay. Moby.
Ira,
Oh, someone said something. Go ahead.
Ira, it's Russ. Can you hear me, Ira?
Yeah, very well.
All right. So remember when we used to write notes, consult notes, and type them out to other doctors, and you could bill for what you want. Then all of a sudden, over a few years, every code required 7 pages of garbage.
Yeah.
So you met requirements. So I agree that it's really word gamesmanship. And so it lends itself very well to a program that knows the key words, because that's what the insurance companies are doing. They're making denials in 1 second using AI programs because it doesn't find the words that you need. So it's a game of finding the words and then having some kind of program, just like we do now, these pre-programmed things for level 4 or level 3. You hit these boxes, you just keep those words in there, and then they don't have the denials ammunition. The other thing that I've done is I understand what their barriers are, and I try to beat them to the punch. I tell my patients, you haven't done therapy in a year, go do therapy. And in 2 weeks, if this therapy isn't working, you and the therapist say therapy doesn't work. And then you say he tried therapy, he couldn't do it. So it is just a game, and I don't see why we can't get some type of programs that give us more of an equal footing with what the insurers are doing. And I also agree that, yes, it is a word game, and a lot of the guys who you speak to on peer-to-peers will try to tell you where you fell out and what word you need or what thing you need to get it through. So I think that it's doable for us instead of just booking more surgeries and figuring in a percentage of cases that are going to fall out, that we somehow work with these providers of software programs that allow us to play the game as it is in the year that we're in, because it's moving targets. The next year they'll find something else.
Yeah. And I think Alan Resnick just commented that they changed the game. As we get better, they changed the rules. I don't want to be accused of plagiarism, despite
Mhm.
just graduating from surgical leadership program at Harvard. I don't want to be accused of plagiarism.
Can I make a comment real quick, Ira?
Yeah, Moby, please.
Yeah, so I mean, Russ, I think that's really interesting because it almost begs like a ethical question of basically what we're all doing to some degree is bending the truth to make our documentation match whatever arbitrary rules they decide we need to meet in order to satisfy their authorization
That
criteria.
was done
So,
long ago. Moby, wake up. This is that's
right, right,
the
right.
game.
No, but to your point, I spoke with somebody earlier tonight who said almost never do the people who review these cases look back and check prior claims. So in other words, if you say, hey, I need to book this person for a rotator cuff repair, and I just make up the fact that they did 8 weeks of supervised physical therapy, even if they didn't, that reviewer is unlikely to go back through the claims data to validate whether that physical therapy was actually done. It never, ever happens. They don't do it. They don't have time to do it. And so, in a way, you know, it's true. Like if they're going to force us to play this game, you can play this game because they almost never validate the claims data retrospectively to prove that your documentation is false.
Oh, I'd like to,
Yeah.
Marty Nichols raise his hand there. Marty.
Yeah. So in a world where the question you asked earlier, Ira, was have we done a poor job of policing and physicians done a poor job of policing themselves? In a world where overhead for you guys is 61% and all the stuff always gets put onto your back, why doesn't the insurance company have some onus in this? And if there's been some bad players that have been doing unnecessary surgery, isn't there a simple solution to remove them from the network? And don't they have an obligation to police some of this as well, instead of just punishing all of the good surgeons because of a few bad actors?
That's a great point. I mean, it really is. Um, and that might have been the start of some of the pre-authorization early on, I guess. Amar Kasim, you posted some comment. Could you
Sure, yeah. No, I work closely with Brian Hall at Veradigm on the industry side, and where I see prior auths at is just like eligibility, right? Maybe 10, 15 years ago, our staff used to call the payer and said, does Brian Hall have Sigma? Does Beth Best have Medicare? And then slowly practice managements and EHRs had the ability to check eligibility real time so that person wouldn't call anymore, but they'd click a button. And now it's based off the schedule. When you schedule the patient, it will automatically check eligibility 33 days before the appointment and let you know, like, hey, this patient isn't eligible. So what I posted are the initial rules, which aren't going to help us anytime immediately in 2024, 2025, but starting 2027 for Medicare Advantage, if you look at the CMS memo, payers have to at least start opening APIs. APIs are how apps are built, how our phones in our pockets, how all these apps on our phones. So payers have to start releasing APIs to do this all programmatically. So we don't have to, I forget which physician said they just hired someone today whose pure job is to do prior auth. So I do see that we're going to solve this. It's going to take software, and it still looks like it's 3-4 years away, but it's just like eligibility for those who've been doing running medical practices. Eligibility was a very manual process, and now it's something that your staff hopefully only looks at the 1 or 2 ineligible patients, and the other 998 ones are automatically checked. So, but that was it, Doc.
That's a great comment. I'm afraid though by 2027, me, Sigmund, and a few other people will probably just be finishing our fellowships by that time. Um, we'll see what happens. I would like, as most of our topic sessions at Journal Club, again, I want to thank Veradigm. We have 5 minutes, and at the 5 minute point, I like to get some summaries of some people. And especially, let's go to our panel. I'll start with the one real fro. And let's see a photastic summary from you.
Yeah, I mean, I think at this point, this is sort of like nuclear deterrence, right? The insurance companies have all the same AI tools that we do, and they're going to develop AI tools to be able to decline the stuff, and we're going to develop AI tools to try and figure out a way to get it across. I think that we as physicians, all doctors are not created equal, all outcomes are not created equal. If I were the CEO of Blue Cross Blue Shield and I was trying to decide who was going to be doing the surgeries for my patients, I would be analyzing the outcomes of the surgeons. I would be looking at their reviews. Are patients happy with them? And I would say, if you're going to do a 27447 for Blue Cross Blue Shield in Massachusetts, here are the 15 surgeons that are going to do that surgery for you. Otherwise, you need to find someone else. So we have to do a better job in letting everyone know how well we're doing, how good we are, and how different we are. So that's my thoughts.
All right, Brian Fuller.
Yeah, I mean, I think Dr. Plancher said it's a game, gamify it. That's kind of the summary, I think, whether you book too many cases or whether you employ AI or as he mentioned, we just hired somebody part-time that their whole job is prior authorization, but you got to play the game. And so I'm anxious, about these AI tools and how affordable and feasible they are for people. I'm afraid by the time that rolls around, I may not even take Medicare, but we'll see how that goes, with declining reimbursement. There's a breaking point, and I don't know what it is, and that's a journal topic for another night, as far as that goes. But there's no way for me to pay my staff and malpractice and everything if I'm getting paid $800 to do grandma's knee. So there's going to come a day when that's no longer the case. But anyway, I think tonight was great. I didn't know about any of these AI tools, and I don't know how available they are, but I'd be curious to learn more for sure.
Excellent. And Moby and the Fofro.
Yeah, so different topic, but do more bundled payments and direct employer contracting, and then you can work your way around some of this stuff.
Yeah.
That's a topic for a different night. Brian Hall briefly mentioned Gold Card. We didn't get into discussing that, but that's
Yeah, talk
something.
about that. Mention it now. Yeah. What
Brian,
is
I'll let you
so
take
far?
it, but it's
Okay.
something that people should be aware of, and it may be a way that high quality physicians, if you can prove your merit and
Yeah.
show that most of your cases do pass prior authorization, they may allow you to opt out at some point.
Yeah.
Brian, you want to further
Yeah, I'll just say,
divulge on
yeah,
that?
Now
add
you want to
that.
bring us home? Bring us home as well.
Yeah,
Yeah.
we'll do that. So, finishing up on the gold card, it is trickling down to the state level now too, which I think is going to be interesting with a bunch of states having similar, rules sitting there. We'll know more, I think, as the year goes on. It's been sitting around, as we know, for I think since 22 or 21 when this all started. But I think that is an opportunity, and that plays into I think what Scott Sigman said, right? It's identifying the providers that at least we are doing prior auths correctly and meeting their requirements there. I'm not sure it takes care of the good provide, the top performing providers, but I think it solves some of the problems. So I see that as something that's going to continue. And if you haven't, there's some regs. If I have not read the entire reg, I've actually downloaded it the other day to look at again, but there is a bunch of opportunity there. And again, it is trickling down to several states. I think there's 10 or 12 now that have a similar bill being pushed through. So that's one way to solve it. I do think, unfortunately, it is an arms race. I think there is technologies until we figure out a way to I think have physicians advocating and kind of creating that outcome driven piece of it. We're going to have to continue to fight the fight with technology. It's the only way it's going to work. With this API piece that Amber threw up there, and I think Nelson dropped mentioned too. That's a big breakthrough. It doesn't sound like a big thing, but when you start to make it simple like that, it changes the game quite a bit. So I do think until we find a better solution, is a little bit of an arms race and fight the fight. But I think between that and hopefully some of this gold card bills being pushed through, we can change the outcomes, reduce the labor.
Excellent. So we're at 8:59, soon 9 o'clock. I want to thank everyone for joining us. When you get a chance, always we're gonna take this recording, edit it. We're gonna put Moby's hat on Scott, but we're gonna do we're gonna
Moby needs a haircut.
What do you think? Yeah. That's a new children's book.
Yeah.
Oh my God, there you go. So, so I want to thank everybody sincerely for supporting the journal, and sincerely thank Veradigm for supporting tonight's activity. This is a very important topic, and we will revisit it again this year, because we learned a lot tonight, and maybe we'll have another one just on AI solutions and machine learning, and we'll take it from there. So I would like to say good night to everybody, and thank you so much to the panelists and to everybody.